Okay, good morning, everyone. Welcome to Wednesday morning rounds. A reminder, next week is, excuse me, grand rounds. So please sign up for that. Invites have been sent out by Carrie. So this morning, it's my pleasure to welcome Maria. She's one of our 60 cardiology residents to present this morning. She's going to be talking about pregnancy and volume expansion in pregnancy. So welcome very much. Look forward to your talk. All right. Good morning, everyone. Thanks for joining. I'm very excited to be here this morning. So I just want to thank all the attendings and how we put this presentation together, Dr. Garuba, Dr. Schwartzman, Dr. Nguyen, and Dr. Walker. This is the outline for today. We're going to talk about maternal morbidity and mortality. I'll walk you through the adaptations of the cardiovascular system in pregnancy and how we can assess pregnancy-related cardiovascular risk. And then I'll end by sharing all the cardio-obstetric services that we have here locally. So for the first part, we're really going to observe trends and mediators of maternal morbidity and mortality, and I'll review what the adverse pregnancy outcomes, how they impact long-term health. So we'll start with this, maternal mortality. One of the most common indicators of maternal mortality is the maternal mortality ratio, which tells us about the number of maternal deaths per 100,000. And as you can see in Canada, in this graph, we actually have two numbers. This is because the WHO actually accounts for underreporting, and Stats Canada does not. So we see we have a big problem in terms of reporting our maternal outcomes. The countries that are doing better than us from that aspect are countries that really have national strategies to fight this problem. And in Canada, this has been a particularly difficult because we have a provincial-based administration of healthcare. When we look at Ontario, this data is from 2017. It's showing us the MMR for early death in pregnancy, which is the bulk of maternal death happening between the first 6 weeks postpartum. So why are these mothers dying? We see that cardiac disease, cardiac arrest, and preeclampsia are one of the leading causes beyond the usual hemorrhage and infection. Preeclampsia is a multi-system maternal disorder characterized by hypertension and end organ dysfunction, and it has a lot of overlap with cardiovascular disease. So we see that this is really a key player in these adverse maternal outcomes. When we look at women with pre-existing cardiovascular disease, in any really metric, whether it's MACE, heart failure, maternal complications, neonatal complications, they do worse than those that enter pregnancy without a cardiovascular condition. And I'll get your attention to what is this CVD that is seen in mothers. It's not all congenital. We're actually seeing a rise on acquired heart disease in pregnancy, whether it's cardiomyopathy, ischemia, arrhythmia, and I'll tell you a little bit why that is. Number one is maternal age. We're seeing a rise in the age of new mothers, particularly in industrialized countries. You see the rise of mothers above the age of 40. And just for context, from an obstetric perspective, advanced maternal age is actually above 35 years old. There's many reasons for this. Part of it is the evolving role of women in society, but also the evolution of assisted reproductive technology that is allowing women to have children later in life. The other big piece of this is maternal comorbidity. So with the advances of surgical and medical therapy for congenital heart disease, more women are reaching their reproductive years with really complex congenital disease. From the acquired perspective, we know that in Canada, almost a third of pregnancies are complicated by a chronic condition. 2/3 of women are using prescription medications during their pregnancy. 11 smoke during their pregnancy. And there's a big proportion of obesity in new mothers. And we know that obesity actually increases the risk of maternal adverse events by about 25%. Now I want to take a moment to talk about adverse pregnancy outcomes, or APOs, and how they impact cardiovascular health. I think this is something that every cardiologist should be well versed, because virtually every subspecialty will see the complications of these conditions. So what do we mean by APOs? So APOs include everything listed over here. These are adverse reproductive events such as preeclampsia, gestational hypertension, gestational diabetes, preterm birth, and small for gestational age. And this diagram is actually a very recent pooled analysis of more than 20 years of research on how these events correlate with later life cardiovascular disease. So I'll walk you through a few highlights. If you look at preeclampsia, the odds ratio of CVD goes up by almost twofold. For things like gestational diabetes, ischemic heart disease goes up by twofold as well. And some things that we might not think about very much, like preterm birth, are also associated with increased risk. To really take this message home, I'm going to show you a few more details about how this may present in clinical practice. So I'll start with premature MI. In this review of almost 400 women with premature MI, so MI before the age of 65, 40% had had a history of APO when the physician asked them. And we're seeing that women with hypertensive disorders of pregnancy are more likely to have premature MI in their 40s rather than their 50s. And preeclampsia was actually the one that had the shortest interval between the delivery and the MI. So these are young mothers with young kids having myocardial infarction. And I just want to mention that most of these MIs are plain old obstructive atherosclerosis. It's not SCAD. So just to keep that in mind. The next point I want to make is about heart failure. So in large prospective cohorts in Norway, we're seeing an increased risk of incident heart failure in women that have had hypertensive disorders of pregnancy. And what's interesting is that we see a dose effect. The more severe presentations, for example, those that have recurrent preeclampsia are the ones that are at even higher risk. So if someone has had preeclampsia, they have a twofold increase in heart failure. And if they had preeclampsia more than once, that risk goes up to 4.6. Same thing goes for atrial fibrillation. This was a very impressive study done locally by Dr. Johnston, Edwards, Coutinho that shows us that when we look at a population from population-based data, hypertensive disorders of pregnancy are associated with a 45% increase in the cause-specific hazard ratio of incident AFib. Not only that, we're seeing this diversion early on with a mean time to event of 7 years postpartum. And the dose effect I mentioned earlier is also seen here. And lastly, premature all-cause mortality. This is data using the Nurses Health Study, where we see that there's a 45% increase in age-adjusted hazard ratio of premature mortality in women that have had preeclampsia. The dose effect is seen yet again. And this is even in the absence of chronic hypertension. And when we take a look at what was the cause of death, the strongest association was for CVD, with an increased hazard ratio of 2.96. So you may be wondering, why is this happening? What is the link between APOs and CVD? This could be a talk on its own, but in brief, there's probably a few pathways that we need to keep in mind. One of them is that it's probably unmasking an underlying predisposition for CVD, whether this is a genetic or an epigenetic component. We do know that APOs are associated with accelerated vascular aging. And this has actually been shown from data from the Heart Institute with Dr. Coutinho as well, that having preeclampsia adds 11 years to your vascular age. The biggest part also is that they share, APOs and CVD share common pathways, things like endothelial dysfunction, inflammation, ischemia reperfusion injury, angiogenic dysfunction, and oxidative stress. And the last thing is that, as you saw, they do share common risk factors. So to summarize what we know so far, pregnancy is still taking too many lives. There's more advanced maternal age, burden of comorbidity, and pre-existing CVD that are putting new mothers at higher risk, and an adverse pregnancy outcome carries long-term cardiovascular risk. So now we're going to switch gears a little bit, and we're going to take a deep dive into what happens in pregnancy. What are the physiologic adaptations? What is normal versus what is a red flag, and how we can assess risk. I'll talk a little bit about the emerging role of echo in the screening for preeclampsia, and I'll mention a little bit about the role of cardiac biomarkers in pregnancy. So we'll start simple. So there's an increased preload in pregnancy. This is mediated by activation of the renin-angiotensin system with sodium reabsorption, water retention. There's also an expansion of the RBC mass, but this is to a lesser degree than the volume. And this is the reason why pregnancy is associated with dilutional anemia, which is actually critical. You want to reduce blood viscosity to be able to perfuse the placenta effectively. When you increase your preload, you're going to have an increase in your stroke volume, which is what you want. And there's a marked decrease in systemic vascular resistance. This is mostly related to increasing progesterone and relaxin and other biomarkers, and also because the placenta is a very low resistance circuit. This is going to lead to a mild decrease in blood pressure. The biggest effect is seen in the first trimester, and then there's a nadir in the second trimester. And then we're going to see a rise in the blood pressure towards the end of pregnancy and certainly in the postpartum period. There's also changes to the autonomic system. So we're going to have a small increase in our heart rate. And I say small, this should be 10 to 20 beats per minute in addition to their baseline heart rate. So we need to be mindful of what is the starting point of someone. If you have an athlete that has a resting heart rate of 50, them having a heart rate of 100 is not physiologic. This is largely driven by hormones, but also by a rise in the baseline sympathetic tone that we see in pregnancy. With that, there's a decrease in the heart rate variability, and there's also a decrease in the baroreceptor sensitivity, which is one of the main drivers of pregnancy-related orthostasis. Now, we increase the stroke volume, we increase the heart rate, we decrease the SVR. Inevitably, we're going to increase significantly our cardiac output by 30 to 50% during normal pregnancy. And a good portion of this extra volume is going to be directed to the uteroplacental unit. So this is a system that wants high flow and low resistance. It doesn't have a lot of auto-regulation capacity, so it really relies on maternal blood pressure. And at term, it can have a peak flow of almost 750 mLs per minute. And certainly pregnancy is a multi-system condition. I just want to highlight a few other systems that impact how our cardiac patients might do during pregnancy. One of them is the lungs. So we're going to see an increase in minute ventilation, tidal volumes, and oxygen consumption. We're going to see a decrease in the lung volumes and in vascular resistance. And most people would agree that a pregnancy, especially if you're after 20 weeks, should be considered a difficult airway. This is multifactorial. There could be airway edema. The gravid uterus is making pregnant women be a full stomach by definition, and they're at high risk for desaturation in the context of hypoxia because they're maximally consuming oxygen at baseline. There's also a decrease in GI motility and variable hepatic function, and there's an increase in GFR due to the increased flow, so therefore decrease in serum creatinine is normative in pregnancy. So now I'll walk you through what we can expect as normal in terms of physical exam, ECG, and echo in pregnancy. So we already talked about the increase in heart rate. It should never be above 110, and you need to consider the baseline heart rate. You may have a relatively low blood pressure, an increase in rest rate, but the saturation should remain normal. You may hear a higher intensity of S1 and S2, as well as a soft systolic murmur in the left upper sternal border, all of which are just reflective of the high flow state. You may hear an S3, but this is usually not readily audible. You need to really position the patient in the left lateral position to be able to hear it. You should not have an elevated JVP, although the pulsations may be very prominent, especially towards the end of pregnancy, and you might have some mild pedal edema. When we look at the ECG, as mentioned, we're going to have a decreased RR interval and maybe some sinus tachycardia. Due to the increased sympathetic tone, the PR actually shortens a little bit. And due to the gravid uterus, you're going to have a bit of a leftward shift of the axis, but it should still remain within the normal range. What happens to the QTC in pregnancy is also interesting. There's a trend for increased QTC with gestational age. And this is thought to be also a physiologic adaptation. As you prolong the action potential, you allow more time for calcium handling and allow for a forceful contraction at the next beat. There's also a concept of increased T-wave dispersion in pregnancy that is not very well understood and could be related to some arrhythmogenicity that we see in pregnancy. Now, my favorite part, echocardiography. I just put this QR code here if people were interested, because actually the UK have been leaders in cardiobstetrics, and they have they have actually a UK Maternal Cardiology Society, and they have linked with the British Echo Society to generate guidelines as to what is normative in pregnancy. So it's a good read and a good reference. I think that we should consider pregnancy as a transient state of eccentric hypertrophy. And this is reflected by increase in LV and RV and diastolic volumes and diameters, while still remaining within normal range. You're going to have an increase in your LV mass it's a bit of a variable range here, 5 to 25%. You're going to have an increase in your relative wall thickness by about 10%. And certainly these changes are much more pronounced in women that have hypertension during their pregnancy. When we think about EF, RVEF, and global systolic function, we see that there should be no significant change. When we look at pulmonary hypertension, we shouldn't see any because despite the increased flow, there's really a marked drop in the PVR, allowing for the pressures in the lungs to stay normal. I'll have to say that more recent data using 3D volume assessment rather than 2D is seeing two major findings. One is that in the third trimester, the volumes and the diameters are probably underestimated when we use 2D. That's not surprising. As the uterus gets bigger, it's really hard to get good images and to quantify properly. But the other thing is that when we use thorough 3D volumetric assessments, we actually see a trend towards a drop in LVEF towards the end of pregnancy. That being said, the EF remains normal, still about 55%, but definitely a trend toward lower ejection fraction. A few other things to note. So the left atrium also enlarges 10 to 15%. The behavior of the aorta in pregnancy is a bit of a complex one, and it's outside what I'll have time to discuss today. But overall, we should not see significant changes in dimensions of the aorta. And up to 40% of women are going to have a trace to small pericardial effusion that results in the postpartum period. A few other things that might catch your eye when you're looking at these echoes. One is that we may develop LV hypertrabeculation that resolves in the postpartum period. Due to the dilatation of the cardiac chambers, we're going to have some degree of mild regurgitation, particularly in the tricuspid and pulmonary valves, but it could also happen in the mitral position in about a quarter of patients. And due to the increased volume, you're going to see increased velocities across your aortic valve and your pulmonic valve. And this is key. This is very important to consider when you're trying to assess a valve area or using the gradients to calculate severity of disease. This is why it's key to actually know the gestational age of the patient at the time of the echo interpretation. And lastly, diastolic function is expected to remain normal. You will see a bit of an increase in the atrial kick towards the end of pregnancy with a taller A wave, but again, it should not alter the overall assessment. And I won't have time to go into too much detail about this, but there's other two very interesting phenomena that we see that contribute to this physiologic adaptation of the heart to pregnancy. One is that there's really a robust cardiac deformation that is seen. So this can be seen by an increase in the LV longitudinal strain rate. So that is really how quickly and how well the heart deforms in all the directions that it does. And the last one is an optimal ventricular arterial coupling. So this is related to vascular adaptations to pregnancy with decreasing impedance, increase in compliance, and really allowing the LV to have a low afterload to pump effectively. So knowing what's normal, we can have a sense of what are the things that should always be considered red flags, things that should prompt further assessment, further testing. So certainly if someone has a loud murmur or overt volume overload, that is not normal. When your vital signs are grossly abnormal with tachycardia beyond what we expect, or desaturation, or a really increased heart rate, this is not normal adaptation to pregnancy, and this should be investigated. And to be able to tailor what is needed and when it's needed, you need to account for what the patient is reporting and what are their underlying risk factors for heart disease. So now I'll take a little bit of a tangent to explore what I think is the future of echo in pregnancy. And this is looking at the left atrium. So we know, we hear sometimes people say that the left atrium is the poor man's wedge, and it actually tells us a lot about the hemodynamics. And I do believe that. So this is looking at, can we predict preeclampsia? When people in this study, they were looking at maternal risk factors assessed at 20 weeks to see how well they predicted incident preeclampsia. They had a success rate of 76%. When they added routine echo to this score, looking at things like GLS, EF, cardiac output, and left atrial area, they improved their prediction by 1%. So the authors concluded that, this is only 1%, not really worthwhile, but I actually disagree with that. This was done in an unselected population. I wonder how this would behave in a high-risk population. They did not use 3D, which I just told you is probably better, especially in second and third trimester. They were using only GLS. They weren't using the GLS rates, which we know has been shown to be a more robust indicator. And they were simply using LA area, which does not account for all the other LA mechanics that we can assess with echo. So the question would be, what about LA strain? Could that help identify preeclampsia in high-risk women? To understand why this could be useful, we need to understand what is happening in the left atrium. So the first thing is strain just refers to cardiac deformation. So we need to understand what's the cycle that the left atrium goes through. So during ventricular systole, the LA actually acts as a reservoir as it's filling, and it's actually dilating. During diastole, it is acting as a conduit, where initially it's very early diastole, rapid filling, and then a plateau of diastasis. And lastly, we have the atrial kick. So the feature that has been mostly studied is LA reservoir. So this is looking at this phase here. And because the LA is actually dilating from its original position, it's yielding a positive deformation percentage. This has actually been studied in very small, most of them retrospective studies in terms of how can it predict cardiovascular disease. So in people with underlying structural heart disease, it has been shown that it can predict incident cardiac events, including atrial fibrillation. And in normal individuals, it actually was shown to predict outcomes of incident ischemic heart disease, heart failure, and cardiovascular death in women. So it's showing promise and definitely needs more study, but it has also been studied in preeclampsia. So this study looked at women that have had a complication of preeclampsia. They did transthoracic echoes at 6 months, and they saw a marked reduction in the LA strain in those that had had preeclampsia compared to normal controls. And this remained positive, this association remained positive even in those that had completely normalized their blood pressure. So again, I don't think we're ready to answer this question yet. I think we need to understand the behavior of the LA strain in normal pregnancy first and see how early it's altered in preeclampsia before being able to study it as a risk predictor, but definitely something to look forward to. So now I'm going to switch gears a little bit and talk about labor and delivery. I know that there's probably many Strava users here. This is not ChatGPT generated. So someone decided to record their delivery, and a workout is a workout. So love that. So the hemodynamics of labor and delivery are very dependent on a multitude of factors. Certainly how the patient enters labor is going to matter, what their volume status is, what are their vital signs. Their underlying cardiac condition is going to play a big role. Do they have obstructive lesions? Do they have a cardiomyopathy? And definitely everything that has to do with the mode of delivery and the anesthetic of choice. I'll walk you through what is normal labor. So you may remember this from medical school. There's 3 stages of labor. Stage 1 is when the uterus contracts until it leads to a 10-centimeter dilation. And there's a further increase in cardiac output during this period, up to 15%. This is because with every contraction of the uterus, it acts like a bolus of blood to the systemic circulation. And certainly pain is going to increase heart rate and blood pressure. Stage 2 is from the onset of maternal pushing until the baby comes out. And this involves certainly Valsalva during maternal pushing with transient drops in blood pressure and cardiac output. when the Valsalva is released and with each contraction, there's going to be a further increase in cardiac output. And this stage is actually quite critical from a hemodynamic perspective. It can be passive, where we let the mother not push all that much and just wait for gravity to take its course. It's active, which is the normal labor maternal pushing, or assisted, where we don't want the mother to push for too long, and we're able to assist the delivery and the extraction of the baby with forceps or vacuum. Now, stage 3 is often forgotten, but is actually critical in the cardiac patient. Stage 3 is the delivery of the placenta. And this is a moment where there's going to be a massive increase in cardiac output because of the relief of that uteroplacental unit. All the blood that was there is now returned to the maternal circulation, leading to a significant amount of autotransfusion and a rise in cardiac output of almost 80%. Also, there's going to be a major rise in the systemic vascular resistance. This is also due because of the placenta being out. There's no more that low resistance circuit. And you're also relieving some of the aortic cable compression that the baby was causing. So this leads to a very high risk of blood pressure and also pulmonary edema in patients at risk. So entering labor euvolemic is key. And we actually have a very old study showing us a little bit the invasive hemodynamics during labor. So these three graphs, the top is the wedge, the middle is the CVP, and the lower one is the uterine contraction that you can see here. So this patient, when the contraction starts, is seeing an increase in her wedge from 5 to 16 and a CVP of 5 to 20, which can be very well tolerated in a normal heart, but could be very difficult in someone with underlying cardiomyopathy or obstructive disease. And I'll point out that here it's written MU. So MU is actually the units in which they measure the strength of the uterine contraction. And I just want to take a moment here to share that this is actually standing for Montevideo units, because it was born and discovered in Uruguay, and Montevideo is actually my hometown, so I remember this well. These two physicians, Dr. Roberto Caldeira Barcia and Dr. Hermógenes Álvarez, they discovered how to measure intrauterine pressure. And this is one of the major contributions from Uruguay to the world of medicine. And it's still used every day in the labor and delivery unit. So it's not just soccer and meat and wine. There's also MU. So the last piece of this part of the talk is going to be the role of cardiac biomarkers in pregnancy. I know that this can generate a lot of debate, and I'll just want to share a few insights on how to use it. So we need to consider that pregnancy is going to affect the levels of NT-proBNP. That's the one I'll be focusing on today. Certainly, we talked about the volume expansion, so it's not surprising that there might be a small rise in NT-proBNP. Hormones and renal clearance are also going to affect its level. And what a lot of people don't know is that actually the placenta secretes BNP. So we probably should stay away from measuring BNP to avoid confounding. When we look at what is normal in pregnancy, in the bottom left, you see that probably in the range of 40s have been described in observational studies. There's an expert consensus, though, that the upper limit of normal in pregnancy is slightly trimester dependent, with a higher threshold of 200 allowed in first and second trimester and 150 in the third trimester. And I'll explain that why in a moment. There's certainly no role for routine NT-proBNP check in pregnancy. However, if you have a clinical concern for heart failure, or if you have a patient with underlying cardiomyopathy that you want to serially trend for pregnancy, those could be two common indications. And what is very interesting is that a lack of NT-proBNP increase in the first trimester actually correlates with increased blood pressure in the second and third trimester. So I think this is very telling. This is probably telling us that this mother has had a suboptimal adaptation to pregnancy, and there's been a failure to decrease the SVR. This is being looking at in terms of whether NT-proBNP in the first trimester could predict later APOs or cardiovascular health. And we actually reviewed the literature on this and showed that one of the key mediators of this problem is really the vasculature. There's still a lot of arterial impedance in these patients. The SVR remains high. The central aortic pressure doesn't go down. So all of these things are beyond the heart. It's also the vasculature playing a key role. So to sum it up, what we have discussed so far, there are structural and functional changes that are adaptations to pregnancy. Look out for those red flags and don't assume that everything is normal because of pregnancy. Keep in mind the gestational age when interpreting a cardiac echocardiography. And the labor and delivery is a high-risk period with rapid shifts. And remember the pregnancy-specific, the trimester-specific COTA for NT-proBNP. So now I'm going to move to the last piece of my presentation, and it's really how can we assess cardiovascular risk? How can we predict adverse cardiac events in pregnancy? So I'll be talking a little bit about the existing risk scores, and I'll walk you through the role of a comprehensive preconception assessment of the cardiobstetric team. So most people are very familiar with the modified WHO classification of pregnancy risk. This is a risk score that divides women in 4 different categories based on their underlying cardiac disease. I'll say a few things about this score, though. First is that it was developed actually not for pregnancy risk assessment. At its onset, it was actually to assess the risk of contraception in patients with structural heart disease. Number 2 is that it was largely driven by expert consensus. However, it has been updated and adapted using more modern day registries and population-based studies in outcomes in pregnancy. The way it works is that based on your risk category, we see an associated risk of maternal morbidity and mortality. So for example, WHO class 4 would be a situation in which the risk of the mother is 4 to 100%, so extremely high, and is technically considered a contraindication for pregnancy. A few other limitations to know, though, is that even the class 4 group is not an exhaustive list of things that put mothers at very high risk. And within the same WHO class, you're actually going to see a different amount of severity of disease. And I'll show you what I mean by that. So this is just to show you a little bit a condensed version of this classification. So in WHO class 1 would be, for example, a repaired ASD. WHO class 2 would be someone that has a repaired tetralogy of Fallot with no complications. Class 2 to 3 would be patients that have HCM, for example, without obstruction. Class 3 would be anyone that has a mechanical valve. And really, class 4 are your very high-risk patients. So anyone that has obstructive left-sided valve disease, low EF less than 30 in a systemic ventricle, a FENTAN that has any complication, severe coarct, aortopathy, pulmonary hypertension. I'll draw your attention to a few things, though. For example, there's a significant amount of pathology that is not represented in this classification. For example, patients with LVADs, patients that have had a heart transplant within the year, or patients with heart transplant that have graft dysfunction or severe cardiac allograft vasculopathy, or patients that have had a previous history of coronary artery dissection. These are categories of high risk, and we would probably advise against pregnancy in these cases. The flip side is also true. So for example, severe coarct, even though it's a class 4, if we meet a patient that is already pregnant, that has severe coarct, we don't necessarily talk about termination or anything like that. And we don't necessarily talk about intervention in pregnancy. We might just follow them closely with serial imaging and just keep a close eye on them. So as you can see, it's much more nuanced than a table. I'll share with you what the CCS proposes that we do in terms of assessing cardiovascular risk. So they tell us to start with a high risk, whether or not the patient has a high risk cardiac lesion. And they define that based on the table here, which, as you can see, has a lot of overlap with the modified WHO classification, with a few nice additives like the coronary dissection. If the patient has one of these lesions, they're high risk by definition. But if they don't, they support the use of another pregnancy score called the CARD-PREG-2 score. And I'll walk you through what that is. So we like the score because one, it was validated and derived from a Canadian population, and it's very modern, and it's modern day data. I will say, though, that it's largely in acquired heart disease, less so in congenital, but it performs very well even in a congenital population. And for this score, the challenge is in the details. I'll tell you what I mean by that. So each predictor is associated with a point system, which is noted in brackets. Then you sum the score and you get an associated risk based on the scoring. The problem is that the cutoffs that are used here are different than what would be normal severity of pathology, like, for example, the cutoff for valve area. And it's also different than the cutoffs used in the WHO. So you just need to be a little bit careful about that when using it. So to give you a few examples, things that would put mothers at higher risk would be if they had had a previous cardiac event, whether that is heart failure, arrhythmia, or a stroke. Certainly, women that are highly symptomatic, NYHA 3, 4, or that have cyanosis are at higher risk. People that are going to have left heart obstruction, as we already discussed. And I'll point to you here that the cutoffs here are not the same as the severe lesions. So for instance, the mitral valve area that gets you a point here would be less than 2, and the aortic valve area that gets you a point is 1.5. People that have mechanical valves are definitely at higher risk, pulmonary hypertension, high risk aortopathy. What is very novel about this score that I think it's one of its strengths is that it actually includes process of care predictors. So if someone has had a late pregnancy assessment, which is after 20 weeks, that on its own is a risk factor. And that is why I'll be spending some time talking about the role of a preconception visit to make sure that we're not in that position. And this is what I was referring earlier, that when we use the CARPREG to refine a little bit the actual risk based on WHO, we see that within a same WHO classification, we actually have a varying degree of CARPREG score, and we observe a varying degree of severity. So I would argue that it's really good to use in combination these scores and not in isolation to get the most nuanced interpretation of the results for the patient. There are a few other scores that we sometimes use. The Sahara score has been developed specifically for the adult congenital heart disease population, and the Devi score that has been developed for rheumatic valve disease in a Southeast Asian population. I won't have time to go over them today. Know that they exist and they can be used. But what I'll say though is that even in a congenital heart disease population, the WHO and the CARPREG-2 outperform the Sahara. So, if you're comfortable with the other two scores, I think that's more than enough. So moving really to the last portion of the talk, I want to show you a little bit what actually takes place during a preconception cardiobstetric assessment. And it's not just one visit. Often it takes multiple visits. It takes referrals. It's really a team effort where we involve the maternal fetal specialists, anesthesiologists, cardiac surgery if needed, and the whole pediatric team as well to really make the best advice for the patient. This is what I would consider the anatomy of a preconception assessment, all the things that we need to talk about. I won't be able to go through all of them today, but I will highlight a few things about those that I wrote in red over here. So first is contraception. Before we're able to say, yes, let's go ahead with pregnancy, if your patient has an underlying WHO or even WHO3 condition, we need to talk about contraception. I know a lot of people in cardiology are uncomfortable talking about this, but I think that in cardiology, what we really like are reversible, long-acting formulation, and that's easy. There's really three things: the intrauterine device, with or without hormones, and a subdermal implant of progesterone. Just a word of caution with vasectomy, because if someone is not contemplating pregnancy but has a high-risk cardiac lesion, they might be interested in that. This is not something that takes effect immediately. It takes weeks. So we need a reliable contraceptive between that period. The other thing is we need cardiac diagnostics. Often to make decisions about whether someone is fit for pregnancy, we need a little bit more information beyond the ECG, the echo, and maybe an NT-proBNP. We really like stress tests that tells us a little bit about how they could tolerate a pregnancy in terms of what's their functional capacity, what's their heart rate, do they develop any symptoms, do they get any EF drop. And we sometimes even do stress tests or CPETs with fluid challenge to add that extra layer of mimicking what would happen during normal pregnancy. This could be particularly helpful in patients, let's say, that have a systemic RV, they would be really at high risk of this extra volume of pregnancy. Sometimes we need cardiac MRI with gadolinium that we can't use during pregnancy. So having the time to get these tests are important. And some of the patients with, pulmonary hypertension or other cardiomyopathies, they may actually benefit from invasive hemodynamics. Medications. I know you've probably seen many variations of this table. I won't go over those details right now, but I want to say that it's often far more complicated than green, red, and yellow. So, there's conditions in cardiology that would really put the women at higher risk if we don't put them on the normal therapy. For example, women that have familial hypercholesterolemia, if they're going to have, let's say, 2 to 3 pregnancies in their lifetime, and let's say they're going to breastfeed, that's leaving the women with 3, 5, 6 years of no statin therapy, which we know is going to be protective from a heart event perspective. There's women that have refractory maternal arrhythmia that need amiodarone, for example. So it's always a risk-benefit discussion. And certainly anticoagulation needs a lot of thought because there's no perfect strategy in terms of risk and benefit for the mom and the baby. The other thing is always discuss heart healthy habits. I just want to point out something about exercise. We love our patients to exercise. We tell them not only it's good for your heart, but it's also good for your pregnancy. There's higher rates of vaginal delivery for women that exercise, lower risk of low birth weight, lower risk of C-section. So there's really a lot of compelling reasons to do it. However, as the cardiologist, we need to be mindful of whether there are presence of pregnancy-specific conditions that would make them at higher risk of exercising. So this is why we need to work with our MFM colleagues to make sure we're all on the same page. So things like women that have had an incompetent cervix or threatened preterm labor, people that have placenta previa, where the vessels of the placenta are in the os of the cervix, and a few other things would really need to be cautious about exercise. Antepartum care. So where is this patient going to be followed? Do they need tertiary or quaternary care type of follow-up? How often are we going to see them? And are we going to be repeating serial imaging during pregnancy? We often like getting a late second trimester TTE because this is really the peak of the hemodynamic load of pregnancy and gives us a sense of how things may go during delivery. Then the labor and delivery planning that really needs a multidisciplinary effort. We can discuss in advance what we think our target gestational age is going to be, and this needs to be individualized. Where is this patient going to be delivered, and who needs to be in-house in an event of a high-risk pregnancy? For example, people with aortopathy, do we need to have the cardiac surgery availability during that delivery? And then planning of how we're going to monitor this patient during labor and delivery. Do they need a pulse ox? Do they need telemetry? Do they need arterial line or an invasive pulmonary catheter? How are we going to manage their device if they have one? And this might seem basic, but it's actually quite complex and requires a lot of logistics. The best example is how many people have tried to get telemetry in the labor and delivery unit. It's very hard. The nurses there are not trained to read telemetry. So we need to orchestrate this in advance. We need an ICU nurse to read it. So there's a lot of planning that goes into play. And still in the labor and delivery planning, how are we going to deliver this baby? Vaginal delivery is still preferred for most patients. We need to discuss in advance and let the patient know what the recommendation is going to be about that second stage. Some of these patients we're going to say upfront use of forceps or vacuum, let's say, to reduce the amount of maternal pushing and maternal Valsalva. There's really few maternal indications for C-section. And this is a big problem because we see that registries, maternal cardiac disease is still getting women to have C-sections that are probably not indicated. A few exceptions to that would be, severe aortopathy. If someone comes in labor and is fully anticoagulated on a VKA, if they have severe pulmonary hypertension, although that is debated, and if someone gets completely decompensated. And the type of analgesia anesthesia is also important. Certainly during labor, we want adequate analgesia. That's going to limit the spikes of heart rate and of blood pressure. That's going to have a benefit in the hemodynamic tolerance of that labor. And lastly, we need to put the patient into their own context, right? We can plan all these medical things, but we need to remember a little bit about what are the social determinants of health and the support system of this patient that is going to play a big role in how they're going to do in pregnancy, postpartum, and beyond. So getting to know your patient a little bit, what is their support system at home? What are their financial supports? How we can help them achieve their goals? So To sum it up, there are validated scores that are best used in combination and that can inform risk and also antepartum and postpartum planning. And the preconception assessment by the cardio-obstetric team is really key to make sure that we have a safe pregnancy and a safe delivery. So to finish off, I just want to share everything that's available locally for cardiobstetric care. So certainly we have the cardiobstetrics clinic at the Ottawa Hospital, and this is just a list of the conditions that are commonly seen in clinic. And I'll just point out that pre-pregnancy counseling is on its own an indication for referral. So we have time to do all of these nice things that we want to do in advance. We also sometimes do inpatient consultations or multidisciplinary rounds as needed when there's a complex patient. The complex congenital heart disease are seen by the ACHD group, and we really have an amazing team at the general and at the civic with regards to maternal fetal medicine. There's once a week, there's a specialized cardiac MFM clinic that co-follows patients with the cardiobstetric clinic. There's OB medicine and a postpartum vascular medicine clinic. And then for the women that do develop APOs and that are high risk of later life cardiovascular disease, our cardiac rehab center actually has a pregnancy-specific cardio-prevent program where they do multiple weeks of coaching for these patients to ensure that we're tackling all their risk factors and we have a good understanding of their future risk. And with that, I'll thank you and I'll take any questions or comments.
Thank you so much, Maria. There's a question online. Is there any, or are there any irreversible structural remodeling of the heart with multiple pregnancies, so multiparity?
Yeah, that's an excellent question. We do see that women that are really multiparous, so this is defined as more than 4 pregnancies, have a signal towards increased cardiovascular events. We do know that women that have had APOs, particularly hypertensive disorders of pregnancy, they're going to have cardiac remodeling seen by LV mass, abnormal strain, years even down the line from their pregnancy. So there are long-lasting effects to that for sure.
Lots of questions in the audience.
Thank you for an excellent talk. You mentioned initially the adverse pregnancy outcome predict future cardiovascular events. Do you know if we sometimes we use aspirin to prevent preeclampsia? Do you know that if we prevent these adverse pregnancy outcome in high-risk women, does this translate also in a better outcome in the long term? And the second thing is, you said that probably the women identified to be at high risk, they receive counseling in the prevention clinic. Do you know, does this work? Do they really have a better outcome, or it's just yeah?
Yeah, those are difficult and excellent questions. So to begin, so just to clarify, there is a role for aspirin early in pregnancy until delivery in women that are felt to be high risk of APOs. So this would be someone that has chronic hypertension, obesity, other risk factors. Whether or not the use of aspirin reduces the risk of long-term cardiovascular disease, I don't think we have that answer because the real problem is when you develop the APO, whether you were on aspirin or not. If you develop preeclampsia despite being on aspirin, you're going to suffer the cardiac remodeling that comes with that preeclamptic pregnancy and the associated long-term risk. So I don't think that we have a stratified analysis of whether aspirin attenuated the long-term risk in someone that did develop an APO, but it would be an interesting observation. And the last thing was whether or not these, counseling events help reduce later life CVD. I think that the answer so far is probably. We know that women that undergo the cardio-prevent program, for example, and there are centers that actually have cardiovascular event in pregnancy-specific cardiac rehab, they, know much more about their heart. They become stronger advocates for their health, and they recognize the signs of heart disease way earlier. So all of those things are protective because they're going to seek care when needed. I still hear a lot from these women that their care providers are not aware of this link and they're dismissed often. So I think that empowering these women is probably an important mediator of reducing their overall risk.
Thanks so much, Maria. Great talk. As cardiac surgeons, we deal with these patients quite often. We operate on them for SCAD, aortic dissection. Um, as you know very well, sometimes cardiac tumors like myxoma and even coronary artery disease in recently pregnant or pregnant ladies. And it's unbelievable. So I have two questions for you. One, very simple. Where do we draw the line with regards to preeclampsia and hypertension in pregnancy? There's one of our colleagues here was on the basic science side, and I won't name whom, but he came to me a few years. We can't have children anymore because so and so his wife had severe hypertension with preeclampsia. So where's the line drawn with regards to that for you as a cardiologist, saying it's probably not a good idea to have more kids? That's my first question.
That's an interesting question. So here's the problem. We see that women that have had one pregnancy complicated by preeclampsia are able to have subsequent pregnancies without preeclampsia, even those that do not take prophylactic aspirin. So we're not good at predicting who's going to have recurrent preeclampsia. That being said, if someone has had already 2 preeclamptic pregnancies, there's definitely a discussion that goes on about avoiding future pregnancy because she's already starting off at a disadvantage. The caveat to that is if they had a recurrent preeclamptic event without having taken aspirin, some people would say, okay, maybe if we take all the preventive strategies, which is not just aspirin, it's also exercise, calcium supplementation, maybe we can protect them from another preeclamptic event. It's a risk-benefit discussion, and ultimately people are going to do what they want to do. So we need to inform them and accompany them through whatever they choose.
Cool. My second question is, I feel bad. There's actually a case right now in the Heart Institute. I think Dr. Matthew would know. And there's a young 39-year-old woman who came in on the weekend with some of the top 2% worst coronary angiogram you would see at the Heart Institute, like occlusion of the LED of the right, severe circumflex disease. And basically, my question around this patient, and she's on the 4th floor right now in 4-bed 2, and maybe you should see her because it's almost like maybe not quite a case report, but it certainly is quite illustrative of the problem. And I feel that our medical system is not sufficiently astute to have picked up on signs. This lady had 3 kids. She was severely hypertensive. She was poorly controlled hypertension in the community. She had an episode of quote unquote myocarditis with troponin rise in 2018, which again wasn't caught on. And it was felt to be myocarditis. It was pure coronary artery disease. In 2018, she had those diseased arteries that was starting for sure. So we kind of, this could have been prevented. I'm going to paraphrase, like during COVID, we were making the point as leadership of CCS that remember, there are more lives lost and young lives lost from heart disease than from COVID. So focus on heart disease. This is the uber representation of that. I think young women around pregnancy who lose their life or potentially lose it, the life of a whole family that goes there. So there's so much impact, and I feel that we're not making it. So as part of your program and your plans, how can you catch more of these people in maybe effective secondary prevention after her last 3rd pregnancy would have prevented what we see? She's doing great. She's on the ward. She had cabbage times, total arterial cabbage times 4. There was a patient of a Zishan who she sent over, but it's quite the compelling case. And she's within the walls of the Heart Institute, obviously not that uncommon, but I just wanted to hear your thoughts as how we can do a better job as a medical system to catch these patients.
Yeah, I mean, that's a very impressive story. I think that there's a few things that we should do and that are happening. One is that sometimes change happens from the top. So societies like SOGC, the OBGYN Society of Cardiology of OBGYN in Canada, is really trying to streamline our approach to maternal outcomes from a national level rather than just working in silos per province. That's one thing. More close to us, though, I think that it really goes a long way in terms of educating the healthcare providers. So we're doing a lot of work in terms of going back to the medical schools and teaching this association. Half of the medical students are going to become GPs. They need to know these are the concerns and how to follow these patients. The other one is empowering women to know what their risk is. So we do a lot of talks at events from like university students or sororities where we go where the women are essentially to tell them about this risk. And the other thing is that we don't need to reinvent the wheel. One of the things with postpartum care is that women are oftentimes already going to see a medical provider for their baby. They have well baby checks literally every week for a couple of weeks postpartum. So we're really advocating to make it a well mother as well. Check the blood pressure, talk about their symptoms, let them know what their red flags are. The system is there. We're just not utilizing it to benefit the mother. So I think those are a few of the structural changes we can do to prevent situations like this.
Hi, it's Habiba. Sorry, I'm just virtually
Can you hear me?
coming in. Just wanted to add to that point, also made by Mark Ruel, that part of what we do is also educating OB providers, right? So sometimes the first point of contact with the healthcare system for some of these women is when they become pregnant and when they actually see their family physicians or obstetricians. And if, their pregnancies are complicated by preeclampsia, et cetera, or hypertensive disorders of pregnancy, we really encourage referral to our Cardio Prevent program. So the question was raised as to, whether this program actually makes a difference in long-term outcomes. Ideally, if we are able to capture these women early, increase awareness among them and their providers, there are certain tangible things that come out of it. So people pay much closer attention to blood pressure trends in these women over time once they know that the risk exists. The second thing is these women get lipid screening very early on, because we know that preeclamptic pregnancies increase the risk of developing coronary artery calcification 10 to 15 years earlier than their counterparts who didn't actually have preeclamptic pregnancies. And so it's considered a risk modifier with the Canadian Cardiovascular Society dyslipidemia guidelines. So if women have had preeclampsia, you actually are meant to include it in your CAD risk calculation and potentially get these women on statins at earlier thresholds than you would at women of the same age who don't have those specific complications of pregnancy. So there are actually some tangible things you can do. Our Cardio Prevent group participated in a trial called Improve, which was aimed at looking at whether or not programs like this, which influence glucose control, lipid control, and weight loss, trying to achieve pre-pregnancy weight by 1 year postpartum, actually makes a difference. And we saw that it did. Obviously, the data is yet to see what happens 10, 20, 30 years down the line. But a lot of education, both among patients and providers, is really necessary to be able to capture women like the one you've mentioned that's currently in the CCU.
That's okay. No worries. That's great to get Habiba's comments. Great talk and very comprehensive, very well articulated. You're clearly an expert, which is fabulous. I have two questions. They kind of relate to the earlier questions a little bit. You talked briefly about certain series of tests that can be performed in people, et cetera, with known cardiac disease. How predictive are they for developments of problems, events, et cetera, and whether interventions can prevent such events if you've identified them?
Yeah.
That's my first question.
Well, thank you for the feedback. And that's a good question. And I don't have a satisfactory answer. The reality is that for most of these tests, like the stress test before pregnancy, for example, we don't have robust data telling us, okay, if you reach this, you're going to do well. If you don't reach this, you're not going to do well. In the guidelines, they actually use a VO2 max of 35 to be reached, at least to be, showing us that you maybe do well during pregnancy, being able to reach a heart rate of 150 without symptoms. But this is based on very small observational studies that are quite old. So I think that there's definitely a role for us to be leaders in that area in terms of correlating how the results of our stress test do in terms of predicting outcomes. For now, though, I do think that at least they gave us more information, and we could use a bit more information when chatting with someone that is deciding whether to go ahead or not with a pregnancy.
Thank you. So my other question is a little bit related to the discussion around preeclampsia, hypertensive disorders, et cetera. So we know that this is a risk factor, as Habiba and yourself have identified, have mentioned. But do we know before pregnancy what are the risk factors for developing preeclampsia? And can we intervene at that point through screening, detection, intervention, et cetera?
Yeah, definitely. So there are definitely well-recognized risk factors for preeclampsia. Having a previous preeclamptic episode is one of them, so that one is fairly easy. Maternal age is another one. Age more than 40 puts women at higher risk of preeclampsia. People that have inflammatory conditions like lupus, they're at higher risk. People that have had previous hypertension or that have underlying structural heart disease are also at risk. So certain ethnicities are also at higher risk. There's some interesting data about smoking and partner, whether it's the first pregnancy with one partner and things like that, that are a little bit less clear. But we do have a pretty clear list of people that are at higher risk. So what we do, ideally, if we meet them before being pregnant, we talk about risk reduction strategies, which are, there's a few that have been that are evidence-based. One is the use of aspirin. So low-dose aspirin started around 12 weeks of gestation up until 36 weeks, sometimes even up to delivery. This is critical. We need to see these patients early because they need to start the aspirin before around week 12. This is to prevent abnormal placentation, which is one of the drivers of preeclampsia and other hypertensive disorders of pregnancy. And then we talk about diet. If women don't have sufficient calcium in their diet, that has actually been linked to preeclamptic pregnancy. So we would supplement that. And then exercise. Exercise is the number one thing they can do in pregnancy to reduce their risk and then inform them about the signs of preeclampsia, knowing about the headache, the right upper quadrant pain, the swelling of the hands, blurry vision. So they're aware of that. And sometimes we even get them a blood pressure cuff from the get-go so they can get used to how to take the blood pressure and they're not checking it for the first time when they're feeling well. And then serial monitoring. These are patients that are going to need frequent visits, frequent OB assessments because the preeclamptic pregnancies can have small babies. So there's a lot that